Thank you so much for the kind introduction, and a special thank you to Sudeep Gupta and to Shani for the kind invitation to bring me over to talk. So I'll give a brief overview of hereditary breast cancer and what's been updated from the last year. We know that germline pathogenic variants will be found anywhere between 6 to 17% of contemporary breast cancer cohorts. That's not to say that they cause 6 to 17% of breast cancers, it's really only 5 to 10%. But if we're looking for them in existing cohorts, that's the range we might find. The most common germline pathogenic variant in all populations will be a variant in either BRCA1 or BRCA2. And what we find in terms of hereditary predisposition genes will include, in terms of prevalence, is going to include or be determined by where we're looking. What is the cohort we're looking at? And the reason why that is important is that in certain populations, there will be variants and differences in prevalence of mutations. So it's going to depend on how old the cohort is that we look at. So BRCA1 and BRCA2 increase the likelihood of early onset breast cancer. The subtypes, so triple-negative breast cancers, we're more likely to find particular pathogenic variants. The stage of disease, as well as the ethnicity of the population, and this will be highlighted through my talk as in publications that were presented this last year, published this last year. So why are hereditary predisposition genes important? Why do they predispose to cancer? Well, the majority of these genes are on the DNA damage repair pathway, and we can see that all the usual offenders when it comes to pathogenic variants, hereditary variants, are along these pathways, including BRCA1 and 2, PALB2, ATM, CHEK2, and RAD51C and D. Part of our challenges at the moment when we practice is what we do with all these other non-BRCA moderate to high penetrance genes. We already have a plethora of data about BRCA1 and 2, but we're now finding a lot of other information. We're using more and more multi-gene germline panel tests, so we're identifying more of these previously unidentified moderate to high penetrance genes. We're using more genomic testing in advanced breast cancer, as we saw in the earlier session in the molecular tumour board. And as we do so, we will also identify germline pathogenic variants that had previously not been detected. I must say that we can't, at this point in time, rely on genomic testing of tumours in place of germline testing. That's a lecture in and of itself, but it's an important point to emphasise. And now, for all these non-BRCA moderate to high penetrance genes, we have limited data, both on how to screen these patients, what are appropriate risk-reducing measures, and what is the optimal oncological management for these patients. And we still have relative limited data on phenotype and disease course, although there were some publications this last year that will shed some further light on that. And before we jump forward, just to outline the standard of care for systemic therapies in 2023 for hereditary breast cancer. In the early setting, we have the Olympia study that you're all familiar with, which is the addition of adjuvant olaparib after standard adjuvant care in patients who are either triple-negative or hormone-positive HER2-negative who have a germline BRCA mutation. You'd all be familiar with the improvement in the invasive survival data, but what was then later published this year, and it was presented early in 2022 and now it's published in the Annals of Oncology, is that in fact the study also reaches its secondary endpoint, and olaparib demonstrates a significant overall survival benefit. And we see an overall survival benefit at a 3 to 4 year follow-up of 3.8%, at the 3 years, 3.4 at 4 year, and looks like the curves are open and may continue to open. And this is very significant in the breast cancer setting. Importantly, when we looked at the distant disease-free survival, we can see that there's a 7% benefit in favour of the olaparib arm. And I think the one other thing that's really important to keep an eye on in this group, and we'll have to follow very closely because this will never meet tests of statistical significance, is that we can see that there's a pattern. And if you look over here in the olaparib arm compared to the placebo arm had more new primaries than the olaparib arm did. So it seems that these patients are getting a benefit beyond their breast cancer, but that requires further follow-up. And I think that's something very interesting to keep in mind moving forward. The other important study, not from this year, but needs to be mentioned, was the neoadjuvant study with talazoparib, which was a very brave study that gave neoadjuvant talazoparib to patients with a triple-negative, the majority of them had triple-negative breast cancer, and they all had a germline BRCA mutation, with remarkable pathologic complete responses. Literally as we speak, the study of the Olympia N study, which is a neoadjuvant study looking at olaparib with immunotherapy is opening in many sites around the world, and I think that will be an interesting study to keep our eye on. The other important study that was presented at San Antonio this year was the JEPA-OLA study. And in the JEPA-OLA study, this study looked at giving neoadjuvant therapy. There was a standard arm that received epirubicin and cyclophosphamide, and before that they received paclitaxel and carboplatinum. In the study arm, they received the same chemotherapy, but instead of the carboplatinum, they gave olaparib, which brings up the question of the olaparib versus carboplatinum comparison, which we have very little of, unfortunately. It's worth noting that the olaparib dose here is lower than the standard olaparib dose, but it was being given here with chemotherapy. And what we can see is that even in the germline BRCA patients, there was no statistically significant difference in the pathologic complete response rate. It appears that when it comes to distant disease-free survival, olaparib did not perform worse than carboplatinum in the germline BRCA patients, but it didn't perform better. And in the patients who did not have a germline BRCA mutation but did have HRD scores, olaparib did not perform as well as carboplatinum. So I think there's a lot of important lessons that we can learn here for our population of patients. And just to remind everybody that an ongoing issue for our patients with hereditary breast cancer is that olaparib is a great drug. We do not know what its clinical impact is on fertility, even though there is preclinical data that would be concerning. So it's something that needs to be discussed with our young patients. In advanced breast cancer, we have a standard of care. We have several studies that have established the role of PARP inhibitors, and I'm not going to delve into that further. The other important study in recent years was the olaparib expanded study, and what we saw in that study is there were two cohorts, one with somatic mutations, one with germline mutations, and the bottom line in this study was that the patients who had germline PALB2 mutations over here had an outstanding response, and we actually identified another group of patients with hereditary breast cancer who can benefit from a targeted therapy. And it also sort of breaks our pre-specified ideas or concepts that these sorts of tumours are always triple negative. Well, in this study, the majority of the germline PALB2 patients had hormone-positive breast cancer. So if we look at overall at the different types of high penetrance genes, we can see that when it comes to high penetrance genes, the only mutation that we have any systemic impact for in terms of treatment is PALB2. And if we looked at the moderate penetrance genes, for now systemic therapy should not be altered according to the presence or absence of any of these pathogenic germline mutations. So what's new from the last year in other aspects? So I'll just I'll touch on a few of these issues about who to test, variants in mutational landscapes, risk of other malignancies, risk of contralateral breast cancer. This has to then, of course, to do with risk management and an interesting paper on biology. So who are we going to test? So there's an argument today, should we be testing everyone? Should every breast cancer patient be tested for BRCA if we have options for adjuvant therapy? So 5 to 10% of our patients will be BRCA positive. Is that a good justification to do genetic testing, universal genetic testing? So this is an interesting study that was published in the JAMA Network Open, and this showed what would happen if we tested everyone. In other words, we're not going to just test people that meet guideline criteria. These guidelines or criteria are really largely already outdated. And was it going to change patient management? So the interesting thing was that when they tested patients for a pathogenic variant in the subgroup that met inclusion criteria for current guidelines, the detection of a pathogenic variant was 8.8%. When they tested the group that didn't meet the guideline criteria, they found 8.4%. In other words, when we test people who don't meet criteria, if we don't test people who don't meet criteria, we are going to miss 50% of pathogenic variant carriers. So that's already one argument that we should be doing testing. The other thing was that they checked what the clinician reported impact was of the germline testing. And what we saw was that in patients who did not meet criteria, the detected pathogenic variant, because of the testing that was done in this study, changed management in nearly 60% of patients. So this is really going to have an impact on how we manage our patients. And when they looked at the doctors about how their recommendations were going to change, we can see that the imaging follow-up, the chemotherapy strategy, the surgical strategy, all changed dramatically when the physician knew that there was a pathogenic variant. And I think the important point from this one is it's important to know it changes our practice and our management, and we're going to miss 50% of our patients if we stick to strict guidelines. What about variability across populations? Because universal testing, while I am a proponent of it, is not going to be readily available in most countries, including in my own, because of cost. So how do we know who needs to be tested and where? Well, first of all, we need to make sure that we're not testing using calculators that are not suitable for the population that we're testing. So until now, most of the calculators, the PENT 2, Boadicea, CoCal, and there are several other calculators, have been based on populations with European ancestry. Is this the best way or the best guide for assessing risk and likelihood of a genetic mutation in a population that is Southeast Asian? Well, the answer is no. So this is a paper that was actually published in the JCO earlier in 2022, and they developed what was called an Asian risk calculator. And they incorporated age of diagnosis, ethnicity, family history, bilaterality, tumour biomarkers and grade. And what they found was using this Asian risk calculator based on an Asian population, this improved sensitivity and specificity in identifying patients who are likely to carry a BRCA mutation. I think this was a really important publication, and I think we need to be seeing more of these publications and further validation of these tools to make sure that our guides for testing and who to test are appropriate for the population that we're looking at. Another interesting study that was printed just at the end of 2021 was a paper that looked at the mutational landscape of hereditary breast ovarian cancer in the Indian population. There are other publications from India, but this one caught my eye, and it shows the importance of doing profiles on populations that are not necessarily of a European ancestry, because once again the patterns here were different. And what they saw in this study is that there were recurrent pathogenic mutations that were found in mutations common for the South Asian population. They also found VUSs that were repeated in other data sets from South Asian populations. And what caught my eye was that these things are important because they are different to studies on European ancestry populations. For example, CHEK2 in this particular study was not detected. It doesn't mean there are no CHEK2 mutations in India. It just means that in this particular study, the numbers were obviously too low. But what we can see is in a European ancestry, then CHEK2 would normally come in here, probably before ATM even. It just shows the importance of thinking about the population we're looking at. In terms of cancer risk profile, what are cancer risks? We know that the classic cancer risks for BRCA1 and 2 are breast, ovarian cancer, male breast cancer, pancreatic cancer, and prostate cancer. This was a very large case control study from Japan, and what they also found was additional associations with biliary cancer, gastric cancer, and esophageal cancer. So we need to take into account that in these populations, in Asian populations, as you know better than myself, there is going to be more stomach cancer and gastric esophageal cancers. So the question is, are we seeing an overlap here? Are we seeing a real association? And you can see here that there was a really big difference, and particularly in BRCA1 and BRCA2, BRCA1 for biliary tract, BRCA2 for esophageal, and both BRCA1 and BRCA2 for gastric cancers. And these associations were much more strongly seen than in European groups. That being said, there was a weaker association with prostate cancer compared to European groups. But in European countries, prostate cancer is more common. So I think this is another important thing to keep in mind when we think about associated malignancies. And this is just the good comparator. This is a study from the JCO. This was based on the SIMBA data, and most of these patients were of European ancestry, also published this last year about cancer risk profile. So here we can see that male breast cancer is associated. We can see gallbladder as well, that there's an association with BRCA1. So that's in keeping with the Japanese study we just looked at. And stomach cancer was also slightly elevated, but esophageal cancer was not listed here, and the association was not as high as in the Asian group. So I think these are things to keep in mind. And as we test more and our databases grow, our definition of what are malignancies associated with a particular mutation will change over time as the databases grow. If there's already a mutation, are all the mutations created equal? So we know to differentiate between different genes as high or moderate penetrance, but what about within one gene? So what about within BRCA genes? Are missense and protein trunking mutations the same? Well, the answer is no. It appears from a study that was actually published this month already in 2023 that missense pathogenic variants that are both in functionally important domains, in the ring domain or the BRCT domain in BRCA1, actually associated with a lower risk of breast cancer than the protein trunking variants. And the cumulative risk by age 70 for a BRCA1 protein trunking mutation was 70%, and in the missense pathogenic variant that was in the BCRT domain, it was approximately half of that. So we need to start thinking a bit more in depth about what risk our patients have, looking into further detail about the mutation that's been identified. The differences were less pronounced in this study between BRCA2 missense and protein trunking mutations, but there was a slightly slower risk from missense mutations in families when the diagnosis was postmenopausal. And for women who were over 50 at diagnosis with a BRCA missense pathogenic variant, their risk level was similar to moderate penetrance pathogenic variants. So I think we need to start looking when assessing risk at a bit more detail. We need to be giving more attention to the family history. We need to be giving more attention to the type of mutation that has occurred. And we actually need more studies to validate these findings before we can apply them to clinical practice. What are the risks of contralateral breast cancer? This is a really important question because we need to know this information so that we counsel our patients appropriately about risk-reducing measures. This was a paper by Yadav et al. It was presented at San Antonio and has just been published in the JCO. And I think this is a really important slide to take a close look at. So we can see that from the stage or the time of first diagnosis of a breast cancer, in ATM carriers, they did not really have a very significantly increased risk of a contralateral breast cancer. So this is a group that we can identify that should not be encouraged to consider prophylactic risk-reducing mastectomy. However, when we looked at BRCA1 and BRCA2, this confirms what we've previously known, that these women have a very high risk of a contralateral breast cancer. This does not mean that all these women need risk-reducing mastectomy, because it also depends at what age the woman was when she was first diagnosed, and we'll look at that in the coming slides. If we look at all CHEK2 mutations, there seems to be an increase in contralateral breast cancer. Is it high enough to justify recommending a contralateral risk-reducing mastectomy? I personally don't think so. These risks are not even hitting 20%. And we can see here, just as a demonstration, again, you need to look at what mutation the patient has in that gene. So in the 1100 del C, which is a common mutation in Ashkenazi Jews, and I see it often in my patients in Israel, they have a slightly increased risk, but the risk is only about 10%. So that definitely doesn't warrant any radical surgery. And you can see that in the PALB2 carriers, if we look at all of them, irrespective of menopausal status or biology, there didn't seem to be a dramatically increased risk. But we need to look in further detail. And so the minute you break these groups down to ER positive or negative, things change a little. So the BRCA1 and 2 patients, they are at risk of a contralateral breast cancer, whether or not they have an ER positive, an ER negative, whether they're young or whether they're older when they're diagnosed. But PALB2 mutation carriers, if they were diagnosed with a hormone-positive breast cancer, they don't have a meaningfully increased risk of a contralateral breast cancer. But if they had a hormone-negative breast cancer, they had a significantly increased risk. In the premenopausal population, BRCA was important, irrespective of ER positive or negative, and we can see here that when it came to patients with a PALB2 mutation, again, in the premenopausal women, their risk of contralateral breast cancer correlated with if they had an ER-negative cancer. In the patients who had the CHEK2 mutations, they had a slightly increased risk, but it was more prominent in the hormone-positive patients. When you looked at the postmenopausal patients, these risks of contralateral breast cancer are much smaller. And so, at least in my clinical practice, when I see women with moderate and also high penetrance genes who are postmenopausal already or had a postmenopausal diagnosis, I carefully discourage them from performing radical surgery because I don't think that they're likely to benefit from it. And here they look at, this is a more easily visualised of what I just said, which is about the risk of a contralateral breast cancer by menopausal status, and we see that there is a big difference between menopausal and postmenopausal, also particularly for the CHEK2. And when they looked at women whose first diagnosis was late, they were over 65, the only number of contralateral breast cancers was 3. So when I see a woman with some sort of pathogenic variant, even if it's BRCA, and she's older, particularly over 55, I tell them they're very unlikely to get any benefit from radical surgery. How do we approach screening strategies in these patients? So there was a very interesting study that was based on modelling, and this tried to ascertain in patients who had ATM, CHEK2E and PALB2 mutations, whether they got added benefit from both combined mammography and MRI, and what the price was in terms of false biopsies. So this study concluded in their comparative modelling analysis that doing annual screening before the age of 40 reduced the risk of mortality in women with these mutations. I have to say, I'm not convinced about this data. I think it's an important study. I'm presenting it. We don't see those kinds of risk reductions in risk-reducing mastectomy for women with a BRCA1 or BRCA2 mutation. So I think that I would be very wary with this study about how their modelling was done. They did see something that has been repeated and mentioned before, is that if women are having screening MRI, they're not going to get any added benefit from a mammogram if they're under the age of 40. So there's no need to do mammograms on these high-risk patients under the age of 40 if they're having MRI screening, unless, of course, MRI screening is unavailable. Now, if MRI screening is unavailable and they're having mammograms and they're under 40, you need to be aware that the mammogram is not a very effective tool in those patients. So we've looked at what we need to do in terms of screening. We've looked at what happens in terms of their contralateral breast cancer risk. How does this translate into the clinic? Are we careful about who we're giving bilateral mastectomies to? Well, this is a study from Vanderbilt that was also published this year, and we actually awarded it a poster award at the last ESMO annual congress in 2022. And they looked at the bilateral mastectomy rates among patients with different pathogenic mutations. I found this poster very upsetting, but I thought it was so important that Prudence Francis and I thought it needed to get an acknowledgement and a prize. So in patients who had a BRCA1, firstly in all patients, bilateral mastectomy rate was 44%, which I think is astronomical. In the BRCA1 and BRCA2, I can understand. So they had 44% rates of bilateral mastectomy. But look at the rates of bilateral mastectomy in the PALB2, ATM, and CHEK2 mutations. These patients, over 40% were having bilateral mastectomies, and we just saw the numbers. This isn't justified at all, not in the women that are younger, and certainly not in the women that are older. And look at the median age of the patients in these studies. These women, on average, were 50 and above. So this is quite distressing. And when they did multivariate logistic regression, there was no particular association with any particular gene in terms of the decision-making of the likelihood about having a bilateral mastectomy. And I think we need to take stock. This reflects two things. It reflects what the patients don't understand, but it does reflect that physicians don't understand. And this is something that we have a lot of responsibility for. This year we published, and I was very privileged to work with an amazing group of colleagues on this new paper, and we updated the risk reduction and screening of cancer in HBOC syndromes for ESMO, and this was published at the end of last year. And we make very clear statements about the screening. And in terms of screening, we suggest that in the high-risk patients, they should be starting screening from the age of 30 or 5 years younger than the youngest family member with breast cancer. And this is relevant for the BRCA1, the PALB2, the BRCA2 patients. And we think that for BRCA1, annual screening should be 6 monthly with an MRI. There should be 6 monthly MRI because they're very likely to have interval tumours. But for the PALB2, the BRCA2 and the other tumours, we didn't see there was evidence to suggest that they needed twice yearly imaging. However, we were aware that in most countries MRIs are not available sometimes at all, and certainly not twice yearly, so we've suggested an alternative in the guideline. In terms of intensified screening, we suggested that comprehensive assessment, looking at the breast cancer risk, looking at family history, needs to be done to determine eligibility and at what age an MRI should be performed. So I think the Asian risk calculator is something that should be further validated for populations in Asia and Southeast Asia as an aid in evaluating risk level. And in the presence of other high penetrance mutations, which are fortunately rare mutations such as CDH1, P10 or STK, these patients need to start quite early with their screening, and P53 should be started at age 20. In terms of risk-reducing surgery, it is the most effective measure for reducing breast cancer risk for BRCA1 and BRCA2 carriers, and it should be discussed in patients with high penetrance genes, P53, P10, CDH1, some PALB2 families. Nipple-sparing mastectomy is a reasonable alternative to total mastectomy if it makes it more acceptable to the patient, and immediate reconstruction is safe. But I want to emphasise, and we clarify this in the paper as well, is that women who already have breast cancer, and stage 1 to 3 with a high-risk pathogenic variant, as long as they don't have a P53 mutation, they don't have to have a mastectomy. A lumpectomy with radiation therapy is safe. Radiation therapy is safe in BRCA carriers. Radiation therapy is safe in most ATM carriers. The only group of patients who should have radiation avoided almost at all costs, but even there are exceptions, is P53. So our patients can be reassured that they can have a lumpectomy and radiation therapy if they have a BRCA mutation. And we emphasise that different mutations have different risks. We recommended the use of validated risk assessment tools. So there's a tool called CanRisk. CanRisk is predominantly suitable for patients of European ancestry, but it is well validated and it can help aid decision making. But the key message is we don't do the same thing for everyone because each mutation and each family history is different. In terms of biology, so there were two papers that were interesting that came out this year. One was by Mavadat's group, published in JAMA Oncology, and it started shedding more light on the biological phenotype of tumours in some of these other hereditary breast cancer syndromes. So BRCA1 and BRCA2, we saw what we knew. You can get a mixed bag. There are hormone-positive patients, there are even HER2-positive patients, not many, but there are. And there are and then of course the triple-negative breast cancer, which here is off the chart. BRCA2, you can see more of any type of biological subtype, okay? Triple-negative, HER2-positive. But look at the ATM patients. The ATM patients, they're at increased risk of breast cancer, but they're increased risk of hormone-positive breast cancer. So if you have limited resources and you decide what genetic testing you're doing, if the patient had a triple-negative breast cancer, they're very unlikely to have an ATM mutation. If we look at the CHEK2 mutations, mostly associated with hormone-positive breast cancer. In this particular study, none of the patients had a triple-negative breast cancer. So these are all sorts of things that can help guide testing where resources might be limited. In PALB2, you can see all types of phenotypes. Not all PALB2 will be triple-negative. In fact, in that olaparib expanded study that I showed earlier, most of the patients were hormone-positive. BARD1 appears to be mostly associated with triple-negative breast cancer, and RAD51C and RAD51D are almost exclusively in the cases of triple-negative breast cancer. They increase the risk of triple-negative breast cancer. They do not seem to increase the risk of hormone-positive breast cancer. And the last study that I'm going to look at was a really interesting study presented by Shah et al. This was a group that works with Kate Nathanson and with Susan Domchek at Penn University. And they performed an analysis of matched primary and recurrent BRCA mutation-associated tumours. Not all the patients had germline mutations, most of them did. The sample was small, it was 27 patients who had breast or ovarian cancer, and they found some really interesting findings. And the findings are interesting, and we're mentioning this study because it will eventually have implication for how we manage our patients. Firstly, there was PARP1 amplifications in recurrences. And this is interesting. So it would be very interesting to know, is this different in patients who get adjuvant or maintenance olaparib care in the breast or ovarian cancer setting? That would be something to look at in the future. PARP1 was significantly overexpressed across primary breast cancers and recurrent breast and ovarian cancers, independent of the amplification status, which is also interesting. And the loss of heterozygosity status was discordant in 25% of patients' primary and recurrent tumours. Now, it would be important to understand when these patients were exposed to a platinum agent. Was it before the primary? Was it after the primary? During the recurrence? When was the sample taken? And if there's loss of heterozygosity, or if there's not loss of heterozygosity, this might impact whether or not a platinum agent or a PARP inhibitor is going to work. So these are things that are sometimes when you look at the article, it looks very complicated, it's very busy, but when you just zoom out a little bit, you can see where the important questions are in terms of how these might impact our clinical practice. And the paper identified potential drivers of recurrent disease in these groups, and certainly this paper will help us understand better tumour evolution and further biomarkers to help us select treatment. So in conclusion, risk is a continuum. It varies by gene, it varies by variant, it varies by population and by family history. And if we are not taking all of these things into account, we are not practicing good medicine and we are not serving the population who we work for very well. Screening and risk reduction for individuals with a HBOC syndrome is complex, needs to be tailored based on all of these factors and also on patient preference. And I always teach our students and our young residents, the choice of whether or not to have a risk-reducing mastectomy is going to be very different in a 25-year-old or a 30-year-old woman who is single and unmarried and maybe never had a pregnancy than it's going to be for a 40-year-old woman who may have had 3 pregnancies, has been married for 15 years, has breastfed. And the ability to make those decisions is going to be different amongst them, and we need to think about it and support our patients whatever they decide. The germline testing has implications, and it's not just BRCA. We now know that in advanced breast cancer, a PALB2 germline mutation, those patients likely benefit from olaparib, and we're not going to be likely to see many other studies that repeat this, and certainly not in big numbers. So we need to, often we say, well, let's wait and see more data. Well, we're not going to be likely to see more data, so we need to start making decisions on some of these unique groups. We need to rethink our approach to genetic testing. Are we still going to test by guidelines? Are we going to test every patient that's eligible for an available new biologic therapy like a PARP inhibitor? That might be a better approach. We need further research about how we manage these other HBOC syndromes, particularly the moderate penetrance risk mutations. These patients are grossly overtreated and they are overscreened. It is a waste of resources and it causes harm. And over-aggressive and non-evidence-based screening and risk-reducing measures do cause harm, and part of our Hippocratic oath is not to cause harm. Primum non nocere. So on that note, I'd like to thank you, and I dedicate this lecture to my mentor. Many of you may have known Bella Kaufman. She herself died from breast cancer last year, and she was very active in pushing forward the development of PARP inhibitors and very active in the field of hereditary breast cancer. Thank you for your attention, and I'm happy to take questions.